Hi friends, today we'll be discussing something related to surgery paper 2. Okay, as you all know, the whole surgery paper 2 has been divided into uh, surgery proper and ortho. Of which surgery proper has 50 marks and ortho has 50 marks. Correct. So let us focus on this part now. So what is the pattern? You will get one 10 marker and four 5 marker question and five 3 marker question and 5 MCQ. So what are the portions which is there in second paper of surgery? It is cardiothoracic vascular surgery plus neurosurgery, which comprises of 7 marks. Vascular surgery alone comprises of 10 marks, which has arterial, venous and nervous also, and gastro plus hernias plus pancreas. Together they constitute of almost 17 marks. Okay, and euro. Okay, so the major aim is problem in this part is gastroma. The amount of questions here is very huge, but the maximum marks where you can keep gastro is only at 20 marks maximum. Okay, so keeping this in mind, let us not let gastro first but cover all part of it so that you have the 30 banker marks and remaining you can play it later. You can read gastro, because remember you have to even study ortho. Okay, so this is the paper prediction pattern for surgery paper 2. It's not like paper 1. You can predict things, though there are only 5 topics. You can just play you can just know what is happening. Okay, for 10 markers, either you can get it from vascular or gastro or pancreas. Okay, for example, in vascular, either you can get varicose or DVT, something related to that. And in gastro you might get something related to your appendix. Okay, some easy diagnosable case. A CBQ is the only thing which they can ask, and pancreas itself is a important 10 marker where they can ask acute pancreatitis. So these are the questions which they have asked, but possibly even neuro related question, for example hydronephrosis, can be asked this year. Okay, or even CA prostate for that matter can be asked. Okay, so let us consider this. Okay, I will give you the proper explanation how to go about gastro. Okay, let me come to that part. Okay, next question, one question from neuro or CTVS related to trauma will be asked. For example, spontaneous pneumothorax. Okay, or flail chest. Okay, or you might have SDH or EDH, something related to that should come for 5 marker. And for 3 marker, if gastro or pancreas is not asked, one question from pancreas will be asked in 5 marker. Okay, or from gastro also they might ask you some question related to jaundice or bile duct, something like that. And one question related to uro, for example, here they might focus mainly on kidney, bar prostate, per penis. Okay, so this is the important part. And one question for sure is ward based. What do you mean by ward based? One question might be from hernia. Okay, any parts, any hernia, or something related to vascular, provided it depends on what is the 10 marker. Okay, be clear with that. Then 3 marker, there as I told, the nature of 3 markers in all the paper is unpredictable, but here you can just place it accordingly, provided that one question something related to your law, Kazovier's law, some score, for example, in acute pancreatitis, or some triad or pentad. One question something related to that will ask, where they test you the historical knowledge. Okay, and one question related to your procedure, for example ERCP, MRCP, or endoscopic ultrasound, or for that matter we'll discuss in the rest of the chapter what else they can ask. Okay, one question related to that procedure, either indication, contraindication, or any steps in the procedure can be asked. And either neuro or CTVS. For example, if neuro was asked in 5 marker, CTVS, something related to CTVS will be asked. If CTVS was asked in 5 marker, something related to neuro will be asked. Okay, then something related to euro for 3 marker, for example details crisis. Okay, all those kind of indication, contraindication, those type of questions will be asked. And also one question related to gastro or hernia will be asked. MCQs, as you know, that's the same thing. So how will we go how will the surgery paper to narration will go is, first we'll take up euro, then we'll take up neuro and CTVS, then we take up first we'll take up euro. Okay, then we'll take up CTVS and neuro. Third we'll take up vascular. Fourth we'll take up pancreas, because if you start studying gastro you are out. Okay, I mean it will take a lot of time. I have arranged in that way The gastro narration doesn't go in the sequential narration of esophagus stomach, but I've arranged it based on the weightage and what are the possible questions. Okay, so make sure you stay till that part so that you know what to study. And also, for fifth part we'll talk about the hernia. Sixth part under gastro, what are the important things? We'll place it accordingly and we'll go ahead. Okay, based on that, let's start the revision of our paper 2. The first topic which we are touching is uro. Okay, before these are the 10 markers, 5 markers and 3 markers. So before that, for clinical features of any urology, remember it as storage symptoms. Okay, then voiding or obstructive symptoms, and retention symptoms. And also, if there is infection, then you have to write about fever, pain, and hematuria. Okay, what will you write in storage related symptoms? All your increased frequency, urgency, dysuria, okay, nocturia. And what about your avoiding or obstructive symptoms in BPH? Okay, what is that? Hesitancy, okay, poor weak, poor midstream, okay, or incomplete voiding. And retention, obviously, at the end you will have overflow urine. Okay, so why I'm placing the clinical feature first is, if you know the clinical feature, you can place the disease accordingly and you can just proceed with the clinical feature, because clinical feature you have to write. It's not like pathogenesis, right? So based on this clinical feature, again the investigation aims remains the same: to diagnose the disease, to look for complication, and to further treat the patient. Okay, so based on the same template, let us place the disease. Okay, first we'll go with the kidney. Major question is either hydronephrosis or renal calculi, though renal tumors can be asked, but not an important, but they can be asked. Okay, these are your 5 marker and 3 marker. So what happens in hydronephrosis? Major thing is it's a aseptic dilatation, not septic. It's an aseptic. Then how will you remember the etiology? Either there is problem here or there is a problem outside. So it can be extramural or intramural. In that, if it's in the lumen, then it is intraluminal. Okay, so these are the causes. I don't think I need to explain this. What happens in retroperitoneal fibrosis? It undergoes fibrosis so that it has some dilatation, so you will have the aseptic dilatation. Again, same clinical feature. What will you write? Lutz symptoms. Okay, which I have explained before itself. Pathogenesis, if it's as for 10 markers, write, otherwise don't write. Again, clinical feature, you have to write about fever and Silson rigor if infected. Okay, otherwise don't write this. Then these are the same thing. Investigation, again to confirm diagnosis, identify the level of obstruction. You either go with intravenous pyelogram or urogram or CT. And this is the main thing which in every question you have to write about, to assess the kidney damage. And also at the end you have to do a DMSS scan to assess the functionality. What are the treatment aims? To relieve the symptoms and also preserve renal function. Make sure you write that. And to treat the underlying cause and to prevent sepsis if during infection, and also support it. The same narration. Okay, nothing else, nothing. Retreat crisis can be as per 3 marker. What happens? You will have a mass after you pass urine. It will not be that. That's the same thing. Make sure you write the components and etiology. Enough. Renal calculus. So how can you remember this? CAP, that is calcium oxalate cysteine. Then CAP, uric acid and phosphate. So based on this, again the etiopathogenesis, if it's as for 10 marker or 5 marker, make sure you write it. It's the same thing. Either you might have increased protection or decreased excretion. Based on it, write the same thing. But these major things you just highlight and come up. Okay, it's the same thing. Clinical feature, again I told you, again it leads to recurrent UTI, so you can write about that. And again here you will have obstructive symptoms. So again, what I told as obstructive symptoms, there you can just place it and come back. And also it might get infected, so you can write even this. Investigation, again to diagnose, to look for complication, and to look for the underlying etiology. You can do the metabolic workup as well. These are the treatment aims, where you will classify it as non-operative and operative based on the size of the stone. Will further plan it. Okay, you can if it's a very less sized stone, then you can wait and watch, or you can go with radio frequency cutting, which is this thing. And then again, if it's a very big stone, then you can go and remove the stone. These are the complications. And renal tumors, possibly a 3 marker or a 5 marker. Sometimes it was a 10 marker question, so make sure you just know it. Okay, so again, whenever you're studying tumor, think about the cells which are there. Okay, you have epithelium cell, that is epithelium, and mesenchyme, that is your smooth muscle and or blood smooth muscle component cut. Then you can also have secondary. So based on this, you can just place it and you can do the thing. Again, you can have benign epithelial tumors. Major thing is angiomyolipoma. Then also you can have malignant part of it, which is RCC. And causes of hematuria, same what I told in medicine, place it and come back. Okay, again, whenever you are writing, make sure you write this and write traumatic and non-traumatic. And again, the same thing which I had explained in medicine, go back to that videos, watch it, because it's a easy thing, so I'm not explaining that part here again, because remember you have to complete 2 subjects. Okay, systemic part of surgery and ortho, so I am making sure to cut off things which are not important and just say you where it is done. Okay, so this is the clinical feature and etiology. Again, the same thing, make sure mention about the triad, that is intermittent hematuria, pain and palpable mass. These are the other manifestation. Mention about the staging as well, then investigations, and based on this, these are the options which are based on the staging. We'll decide what has to be planned. Again, Wills tumor, again it's a pediatric based topic, but can be asked in surgery. Okay, the same thing, it's the same narration, but it is a surgical treatment. Okay, based on the stage of disease. Otherwise, you go with art. And TB kidney, same clinical feature, right? TB specific symptoms first, then uro, what it causes, it's an infectious thing. So whatever the infectious protocol of infectious clinical features I told, mention the same thing. Again, this is the same investigation. Okay, nothing less, nothing more. But here in treatment, you will assess the kidney function. If it's not working, why will you keep? So you will go at nephrouretrectomy, that is, you will also remove the ureter. But if it's associated with complication, then if only one part is damaged, for example, only if this is damaged, then you can remove this and you can place this anastomosis. That's what they are saying. Okay, this is an 3-marker question. Okay, they might ask you what is IVP and where do you use it, and cystoscopy. You can just go through that. Obviously, you can have a easy thing. Okay, urinary bladder, not an important topic as such, but I'll just explain you what does it mean. Okay, what does ectopia means? Abnormal site of what? Vesicae, that is urinary bladder. Okay, what does calculus mean? Stone. What does diverticula mean? Sorry. If there is an outpouching of an hollow organ, then it's called diverticula. So you know the meaning, then place it, because it's not that important topic even for 5-marker or 3-marker. I'm just keeping it. So you know the name, then you know how you just go through that. Even if you read it once, you will understand. Okay, so I'm not talking about this. It's the diverticula, nothing more. It's the same thing. Okay, then prostate, very important one. The BPH can be as for 5-marker. Okay, PSA and all those things can be as for 3-marker. Okay, again etiologies, again it's due to the disturbance in the, again you can draw this seesaw diagram and you can just mention about testosterone and estrogen. Imbalance of that will causes BPH. Again, pathogens, if fast for 5-marker, you can write the proper clinical feature is what they will expect here. Okay, again, if it's infectious, obviously you will have probably pain. Again, what is the main symptoms here? Obstructive symptoms are the main thing. Again, but at the end stage, you can have also mention about all. Okay, so these are the differential. On examination, you will do a per rectal examination and you will find all these things. Okay, so again, everywhere during investigation you can place this invariably, and it's the same thing. Okay, so you need not do anything. Okay, but one investigation which you have to write is to rule out malignancy, you have to do PSA, very important. Okay, I think I missed it, but I just saw PSA, so I just remembered it. Make sure you write about that, and also all this urodynamics part. Okay, how do you manage in acute condition? What is happening? Obstruction, so there will be retention, so you need to do catheterization and you have to remove the urine. Then again, if there are any complications, you need to manage it, but surgically mainstay you have to do TEP. Okay, These are the complications. You can write complication due to surgery or due to disease and place it. CA prostate management, I have just written it for the fact that can it be a 10 marker or a 5 marker is my question. So I've just mentioned it, but definitely not for 3 marker. So, but whatever I feel is, though it's common, what we do is it's a Gleason, we do Gleason scores and PSA. So Gleason score is something to do with histopathology, PSA is something to do with biochemical. So based on that, we do risk stratification, whether it's a low risk, high risk, or intermediate risk. If it's a low risk and if the patient is very elderly, like more than 70 to 80, so we just do active surveillance, and if the patient is fit for surgery, then we go with radical prostatectomy. If it's an intermediate, we also dissect out the lymph nodes. Okay, but if it's high, then we have to do surgery and radiotherapy. But if it's very high risk case, then you have to do radiotherapy with androgen deprivation therapy. But even after this, you can try medical castration. But if it's not there, then you have to remove it. Okay. NPSA for 3 marker definition, normal value, indicate wherever it is, where it is increased, and what is the interpretation. Nothing extra I have to mention. Then urethra, 3 marker. What are the causes of stricture urethra and how do you manage it? Again, while managing, you have to go with intermittent dilatation. There is a statement in the Bailey which I have just mentioned. Okay, almost the same thing because you have to give the same narration names. See, 1 10 marker or 5 marker or 5 marker or 3 marker is the question which you expect in Euro. So you should know how will you place the investigation. What is the general template for investigation in Euro? What is the general template for clinical features in Euro? And what is the treatment plan? So based on that, look whether it's an infectious cause, a traumatic cause, or a malignancy cause. Place it accordingly and come back so that you just fetch at least 3 to 4 marks. Okay, so these are the treatment which is present. In hypospadiasis, what happens if the urethral opening, if it's not present in the ventral side, but if it's present in anywhere, okay, then it's called as hypospadiasis. So I'm just explaining it generally, and these are the types where you will find. And treatment is, it's a stage procedure, so you have to do it twice. Okay, first you have to do the procedure to do that, remove the hypospadiasis, then you have to reconstruct it. Okay. This is a proper 5 marker or a 3 mark question. So what is phimosis? If you are unable to retract the purpose over the glands, then it's called phimosis. Can be present congenitally or as a part of complication in infectious disease. What is the treatment? Obviously, you go with circumcision. An indication for circumcision, a 3 marker question, it can be medical cause or non-medical cause. I'm sure you know about this, and also divided into whether it's an absolute or relative. Again, if what are the absolute condition in phimosis, paraphimosis, or CA penis. Actually in CA penis, either you go with half penile or total penectomy, but just it was there, so I've just mentioned. And these are the relative indications. So pernicious disease, what happens? Again, the fibrous tissue which is present there in the corpus cavernosum, it will go fibrous. So it can be either due to traumatic. Mostly it's a traumatic. So these are the clinical feature, and these are the drugs which we have. So nothing. You have to give either steroid or verapamil 10 mg. Okay. So pre-malignant lesions of penis divide into high risk and low risk, or LLL thing, or in the low risk category, but all erythroblockia, Bowen's disease. B is in high risk. CA penis treatment I have not written because of the fact that even though it is present, whatever I studies, because I felt it was more memory based. It took me long to digest, so I just know that you can either have total penectomy or partial penectomy, provided of the margin. If it's less than 2 centimeter from your proximal shaft, then you have to go with total. Okay, so based on that, again the same clinical feature, again you can write ulcerative, all those things. Investigation also same thing. Management, by writing that you just mentioned this. Okay, there is a this is how the narration goes. You can just go back and check what it's extra you can write. Okay, Phonius ganglion, I'm sure you all know this, but major thing is testis is export, but it is viable still. Okay, so again you have to mention about nutritional support, though mention people doesn't mention about, and treat the infection. Hydrocele in and out, I'm sure you know about it. So based on that, you just mention about the Jabulais procedure. Okay, then remaining thing, everything is the same. I am not discussing. Okay, then varicose, what happens again due to the papilliform plexus of vein. In complication, you have to mention about the infertility part. Okay, the same thing. I am not discussing much because you all know it. But basically, you have to write about this because RCC itself also can present just less uh, varicose. Okay, so make sure you know about that, and by writing investigation, mention about that. Again, in testes, these are the three four things which can come. So again, this is the cryptorchidism ka etiology, and these are the complication. So how do you do the testis ka tumor classification? You have Sertoli cells and germ cells. So what does a germ cell can produce? It can produce a baby. So it can be what? Seminomatous and non-seminomatous. What will happen once the zygote is formed? You will have yolk sac, you will have you will have the placenta, so choriocarcinoma, yolk sac tumor, and also embryonal carcinoma. All these things can develop in the germ cell. What about the sex cord stromal tumor? Whatever are there here, okay, which helps in the Leydig cells helps Leydig cells, Sertoli cells. There, even there, the tumor can arise. But you can have both of this germ cell and sex cord cell in the gonadoblastoma, or you can have metastasis also. In the same thing, I'm not discussing. I'm sure you have studied in pathology, but what is the aim? To cure, you can go for eye orchidectomy, and to if there is a relapse, obviously for art. Torsion testis is an important 3-marker or a 5-marker question. So same thing. The major clinical symptom is this. Okay. And how do you do the investigation? You have to check majorly about the viability of testis. Based on the viability of testis, you either preserve the testis or you can remove the testis based on whether it's viable or not. So mention about that and you can come. Okay. So that's it about Euro. So what I would like to say about Euro is, see, Euro has the straightforward narration, not like any other subject in this thing. So either you can expect a 5-marker or 3-marker, though 10 markers are not as till now. So the 5-marker majorly can be from kidney or penis or testis. 3-marker again can be asked from anywhere. So make sure you study those parts. Always have a clinical, always have a general template and try to fit those things. Try to fit every disease into that part, and whatever specific things has to be mentioned in that, make sure you write that specifically and you come back. Okay, that's, and you underline that. Again, neurosurgery and CTBS. What is the core aim of this question is, you will get one short 5-marker and one short 3-marker. This plus or minus, but this is like sure. So the aim is they are testing you whether you have trauma ka knowledge. That's it. Based on this, you just place the disease. So what is the important thing? Where you will write ABC, ABC, ABC. Okay, that's one thing. Okay. Extradural hematoma, subdural hematoma, I'm sure you would have studied in anatomy, then forensic, all those places. Same forward narration. Pathogenesis, if they ask you for 10 markers, then you have to write. Otherwise, you can, I don't think I need to explain also this, but make sure while writing the pathogenesis, you can derive out the clinical features. So write about that. Then again, writing clinical features, though I just mentioned about this, make sure you write about sensory, motor, like how I discussed in medicine, and then write about science of ICP. Okay, this if you want you can, or else you can just skip it out. Okay, and again, investigation is to confirm the diagnosis and to look for complications. Again, the medicine narration, there is nothing else here because it's a core emergency topic. So the narration here, it goes with the medicine part of it. Again, the surgical is what you do at the last, that is as the mainstay. So what you will do, you will do a craniotomy and you will take the cranial flaps. So you do the craniotomy and you raise the cranial flaps and you remove out the blood clot. These are the complications. Okay, I don't think I have to explain much there. So because it's a straightforward thing, nothing extra is not there to explain. Again, this is the main thing, major thing. again the same. So I'm not explaining anything because it's the same thing. Okay. GCS again, it's a 5 marker or a 3 marker question. Again, so what is the score? 15. In and out, I'm sure if you have gone to your emergency medicine, right, left, center, they talk about this. Make sure what write the definition, write about the components, and write about the interpretation. Less than 7, it's an indication to go for integration. CTBS again the same thing. Okay, flayed chest, what happens? There's a fracture in two adjacent consecutive ribs. Then during inspiration, the chest is drawn indrawn, and during expiration, it is drawn outward. So because of that, it is called as flail chest. Okay. So again, these are the It's an clinical diagnosis. I don't know why I have to write about investigation. Basically, we look write about implication. To do investigation to look for complication, and these are the again tension pneumothorax in and out. I think you should know it's the same thing, but what I don't think they have mentioned about that. So again you can go with ICD or second IC again now we do it in second intercostal space at mid-clavicular line. What we do is the thoracocentesis. So make sure about that. Again the same clinical feature. Again you have to draw up at all the system. So while writing emergency, I have told you the template, just place it and come back. What about empyema necessitans? When you place a train, if what is empyema, it's a pus. Okay, you need to drain it. Okay, or that's the major part of the treatment. See, that's it. Okay, then yeah, that's it. So in and out. Okay, this is one of the most easiest thing. See, you will get one sure 5 marker and 3 marker either in one of the 3 questions. So what I would say is a day before exam you should know these things to the point. And just berry aneurysm, I'm sure you know about it, so I've not mentioned it, but definitely you can go back and see what is it about. Okay, so make sure after your euro you study CTVS bar neuro, because one 5 marker and one 3 marker is like sure. Okay, then what about vascular surgery? These are the things which is there in your CE or SRB. Okay, so all these things are important. See, this is the probable 10 marker or a 5 marker, and even can be asked for 3 markers. So in and out of vascular surgery is what I would expect in you, and this is what it's a ward based thing. So I don't think I need to explain much of it. Okay, intermittent claudication, I'm sure you know about it. I'm not talking. What are the causes of limb ischemia? You have to talk with again, whether it's an obviously all will talk about this, but people miss about this. Okay, and diabetes and scleroderma. Now talk about this and then go about it. Again, what is Berger disease and what is Shenoy's criteria? Shenoy's criteria, I think I have written about. Again, you have to mention about it. See, surgeons like so all those procedures names, so make sure you write about it. Okay, Berger disease, is it atherosclerotic mediated? No, it's a non-atherosclerotic inflammatory disorder of medium sized and distal vessels. Again, this is the criteria based on the involvement. So first they start with upper limb, then again they immediately come back to lower limb and go upwards. Okay, this is the major thing. Okay, again to look for the site of occlusion and same thing. So drugs, again we have to address about the pain to prevent atherosclerosis and to prevent claudication. Though it's a non-atherosclerotic, it is in future you might have high chance of. Okay, so the same thing. At the end, you can plan for this, though I don't know whether it's done or not. Okay, then chronic limb ischemia is the same thing, so I'm not explaining much. What happens in Raynaud's disease? Again you will have primary and secondary. Primary, not concerned. Secondary, think about steroid or your rheumatological condition. Okay, don't just go and operate on that. Okay, again I'm sure you know about it, but why did it come here? Due to Berger's disease. Okay, that I'm sure you know about the pallor, then cyanosis part of it, then again the turning into red, that PCR part of it. I'm sure you know about it. Okay, vascular lesion, these 2 questions, these are the least expected thing in vascular surgery. Okay, again what you will do, you might have hemangioma, can be either capillary or cavernous. So based on that, again you see when capillary, nothing to worry, but cavernous, it's a slow growing tumor. Okay, AV fistula, either you can have it or it can be congenitally present. So what is the main thing which you need to hear? If it's an emergency, then you have to go for quadruple dilatation. Venous disease, possible 10 marker or a 5 marker. Okay, so versus triad itself is a 3 mark question. As I told, one question about triad or history, they will definitely ask. These are the causes. Then make sure you mention about this. Okay. Mm. Then obviously I'm sure you know about this. You wait till this? No. You will always check up. It's a pre-clinical diagnosis. If you say even before a clinical diagnosis, it's better if you give low molecular weight. Then again investigation, I have told you the same template, go with the same thing, but here you will do D-dimer because it has a high negative predictive value. Because if D-dimer is negative, then you have to think about other causes. I definitely don't think under DVT or pulmonary embolism. Then again you have to check whether there are any complication. Again, important thing is you have to talk about this. Because when from second year you are studying, it's a possible 10 marker or 5 marker. Make sure you know about it. And again, CEP classification, I think you know. Again, pathophysiology, it might be reflex or obstructive. Anatomic, it can be either due to perforators or it might be due to superficial perforator or deep perforator. Again, etiology, it can be either primary or secondary. And CAP, I'm sure you know C1, C2, C3 and C4. Again, in C4 you have A, B and C. I'm sure you know about it. Again, what are these two means? Edema, then coronophlebotomy, then C1 and C2. Again, here you will have reticular veins, then you will have varicose veins. Okay. Make sure you present it accordingly and come. Okay. I mentioned it. A means pigmentation, B is lipodermatosclerosis, then coronophlebotomy. C5 means yield ulcer, but C6 is an active ulcer. Okay. Make sure you write about it. Again, pathogenesis, please don't keep on explaining this. I know SRB or other books has given pages of these things. My request is don't write about that. Okay. Again, this is the etiology. Same, I know in and out I have discussed in our clinics. I don't think I need to even talk about it. Even surgery also, it's an important thing. So I'm not talking about it, but it's an important 10 marker. But it's an important thing is Biscard regimen, which they will ask for venous ulcer. This is like the conservative management. So next thing is about the lymphatics part. Though you have studied, though it's an important RS question, but least likely it will come because arterial and venous part of it is very important. But possibly you can get a 5 marker or 3 marker from it. This you can refer the medicine part. Again, in medicine, it's a not important thing because as I told, anemia related diseases are more important than platelets or coagulating. Then you have WBC thing. These are the things. Okay. So again, the lymphedema part of it, either you can have primary or secondary. This I'm sure you all know about it. So clinical physiology is also based on this. And this is the grading and aims of your investigation and what are the complications which you see. And major thing is you have to think about infection, and if it's a major thing, you have to go and exercise the thing and come back. I'm not explaining in detail of all these things because it's a important thing which you are studying from past 3 years, so I don't think I need to waste time here because there is also important, this time has to be invested in ortho as well. Okay. Again, what is chyluria? If you pass all the lymph related things in urine, it's called chyluria. Okay. So these are the treatment. The same is the investigation. This drop we are discussing orthopedics. Okay. So this is about your arterial, vascular part of it. Okay, the major thing what we discussed here was major thing is you get 10 marker or 5 marker short plus 3 marker. So for 10 marker and 5 marker, the major thing which they expect is you to know about varicose veins or ulcer or even DVT. These are like the core topics which they expect you to know. Okay, and also for your 10 marker, you might also get questions about ischemia or peripheral POOD. And also for 5 marker, the major thing these are the possible 10 of 5 marker, but for 3 marker they will ask you only about your discards nature, the part of it which you have already studied. So I have not discussed much about it for the fact that you are studying it from second, third and fourth year. Then while studying your GI related things, make sure don't go with the same narration like how you start with peritoneum, stomach and esophagus, because those are the things which are least expected. The pancreas itself has been asked for 5 marker or a 10 marker question. So go with the narration which now I follow, okay, because these are the questions which are possibly to come. It's a stupidity if you study your esophagus, stomach part and waste time in CH stomach, because it's the least likely it might be asked. But if you have the same general template and write few things, you are for sure you can stretch half of the marks. But if you don't follow the same if you start writing the specific things for CH stomach, and if you miss out the questions on pancreas, if you don't study about your pancreas, or if you don't study about hernia in gastro part of it, then you are losing a lot of your marks. Okay, so while starting with gastro, make sure you start with pancreas first. Again, pseudocyst, whether it's a cyst, no. What happens after acute pancreatitis? The pancreatic fluids will get stayed back and forms a cyst. So that is called a pseudocyst. This is the classification and clinical feature. Again, you will have epigastric pain. But what is the major thing? You have to remove the cyst. Okay. But if it's less than 6 centimeter, you wait. But logically, we do go for intervention. And acute pancreatitis, in and out is important. Okay, it's a possible 10 marker if you ask me directly, but can be asked for 5 marker also. So again, you have to mention about alcohol, you have to mention about gallstones, mention about infections. So these are the major important thing. Okay. Again, clinical features, since it's an acute thing, obviously I have to talk about fever if it's an infectious cause, and also all these things. Again, what is the major thing with why patient comes to it's pain. Okay, that's one important thing. Then same thing which I discussed in your medicine part. Okay, then important prognostic criteria is Ranson's prognostic criteria. So why was it divided into gallstone and non-gallstone? If you ask me, it has to be alcoholic and non-alcoholic, predominantly gallstones. Okay, so what Ranson observed was few people with acute pancreatitis was able to come back, was able to do better, but few people was not able, few people were unable to do better. So based on it, he saw with people who had gallstone related acute pancreatitis, he considered all these factors, and with people who had alcohol related pancreatitis, he considered these factors. Whenever this was increased, so he thought that it had a poor prognostic factors. Again, why do you do within after 48 hours? One, to assess whether your treatment plan is correct. Okay, see, for example, what about the base deficit, fluid sequestration? It's a logical correction, whether it is happening. So you would check about that. Then why is calcium the most important thing? Because there's something called as saponification reaction. I'm sure you would have learned in necrosis. One of the type of necrosis which happens in pancreas is your calcified necrosis. So calcium levels will go down, and it's more produced in gallbladder related thing. Again, sugar, if you see here, it's 200 and 220 because of the surge in insulin. Okay, is more in non-alcoholic is what we observe. And also you can see liver is damaged, and also there might be evidence of hemolysis, and obviously it's an infectious cause. Okay, hematocrit drops. Why do we need to check here? It indicates third space loss. Okay, it indicates third space loss. Okay, based on this, now you place things so that you remember it easier. Okay, though this and this almost remain the same, you can write the same thing, but major thing is you have to mention about on admission. Again, what do you do? Conservative. Again, it's an important thing to write about ABC. Again, surgically, obviously you have to remove the pancreatic necrotic material and look for any other complication, majorly pseudocyst. And worry about what? Type 3C diabetes mellitus. Okay. Next, study about appendix, because it's a favorite topic for your surgeons, and also it is a possible 10 marker or a 5 marker. So make sure you study about it. What is important? Osteostrain measurements can be as per 3 marker, or these can be as per 10 marker or 5 marker. I'm sure appendicitis you know about it, so I'm not discussing much. Same things, I'm just highlighting important things, and I'm just leaving it up to you. Okay. mention about this scoring. Then what is the major stay of treatment? Appendectomy. Okay. Again, write about the complication. What I say told in order intro or post-op. Again in post-op, early and late. So what is appendicular mass? If you have not treated acute appendicitis, then the policeman of abdomen, that is omentum, will come and bind around it. So at that time you cannot operate, and you follow this something called as Osner-Sheeran regimen, where you don't disturb. If you go and operate there, then you will have high chances of developing fecal fistula. So you go with conservative approach. But if the patient condition is deteriorating, you have to go and operate and do a appendicectomy. Okay. So I'm not talking much. I will talk about the DDs of appendicular mass. Please give me some time. It's there in the other module in the same paper. Again, hernia, in and out, sure, 1 5 marker. Any hernia for that matter. You should know in and out of the whole part of hernia. Okay. So again, it's something which you are studying from long time, that is from second year, third year and fourth year. So again, I'm just giving you the important topics. I'm giving you the same narration. For example, again you will talk about whenever it's whenever it's hernia, what we will talk about swelling and whether there is pain, and also you talk about irreducibility and strangulation if it is developed. Same thing, you just place it and just go. Okay, these are the complication of hernia. And what are the etiological factors of hernia? Now according to Bailey, they say whether it is a endocrine related disease. Just for your knowledge I'm giving, don't write this, but they are saying some factors which is hepatic growth factors which is present in the liver can go and cause inguinal hernia, is what is the latest theory given in Bailey. But do you need to know that? Yes, you need to know that, but do you need to present it? If you want, you can present, but this is what I expect for a 5 marker or a 3 marker, just to present the same thing and come back the same thing. I'm not talking the same, I'm not even explaining it because I'm sure you know it. I'm just underlying the important things so that you know what to present and what to underline. So that's the aim of aim. Okay, these are the these are the surgeries which you can do. Again the same part of investigation. Okay, one important thing what is there, you have to also look for your BPH and correct any other etiologies here. For example, if it's a chronic cough or whether it's a constipation or whether it's a BPH, you need to treat also accordingly. One important thing that if you want you can mention. Same complication again. If you ask me, don't write this. Again, while writing complication, write about intra-op and post-op. Again, early and late. The rest of it you can just fit it in the same picture and come. What happens in strangulated hernia? Immediately you have to go and operate with an antibiotic coverage. Okay. Again, femoral hernia, I'm sure you know about it. In and out you have to learn. Again, the operation procedure is also something which you have to know. Again, about the umbilical hernia, I'm sure hypom mesh repair, I am sure you know about it. And also Spigelian hernia, all those things are asked for 3 marker, but make sure in and out of hernia you study. Okay, so that's what you have to study after your pancreas. So make sure you study your uro first, then you do your CTVS bar neurosurgery next, then you go with your vascular part of that, vascular system part of it, then you study properly about arterial and venous. You can ignore lymphatic for that sake, then go about your pancreas, then go about hernia. Now you can go about your gastro. Okay, in gastro also I picked up things which you have to study first, then you have to leave at the end. Whatever things you want to leave at the end, you can just leave and go. So again, these are the same things. Gallstones, I'm sure in and out you have seen. I don't know any number of surgeries you would have seen in your OT. There are, what do you mean? Benny, I'm sure you would have explained it. I'm just giving you a note so that you know the narration. You just go back and place it. What is the most common? Mixed stones is the most common. Etiopathogenesis, if it's asked for 10 marker, you write, otherwise don't. Okay. Then clinical feature, what is the major clinical feature? It's an asymptomatic thing. But what happens if it comes and perforates, or if it comes and causes you irritation, then you can develop acute pancreatitis, or you can develop gallstones. So while writing clinical feature, from asymptomatic case till complication, you have to mention. Okay. Till in and out of this, you have to mention. Okay. Then when do you treat a asymptomatic case? When do you operate in an asymptomatic case? Again, if it has a high risk for surgery, and if there is about the stone size, I have to talk, and if there are any other comorbidities, whether if it's an immunocompromised patient, and if it's a polyp which is growing more, if it's more than 1 centimeter. What are the high risk for carcinoma? That belt, endogenetic belt, or if the gallbladder wall is thickened, that is nothing but porcelain gallbladder. So all these things you go for prophylactic cholecystectomy. When and one at the condition where there is high risk for carcinoma, when based on the stone size, when based on the systemic comorbidities. Again, these are the investigations which you need to do. Okay, complication, the same thing. While writing complication, again, if it's related to surgery, you can follow the same narration. Otherwise, you have to talk general and systemic. Based on systemic, divide it each and you just present it. What does cause obstructive jaundice? It's a surgical jaundice. That means without surgery, the jaundice will not subside. So what are the causes of it? Again, you have biliary atresia or choledocholitis. Again, while writing etiology, what did I say? Surgery, traumatic, non-traumatic. Otherwise, you can follow congenital and acquired. What are the acquired things? Again, go with the Robbins. Again, inflammatory, infectious, then neoplastic. Again, what are the two things which is specific to this obstructive jaundice which you need to remember? Obstructive or external compression. Okay. Again, same thing, generalized and local things, because in surgery we talk about though in medicine we talk about, in clinical feature we talk about generalized and systemic. In surgery it is preferred if you talk about generalized and local. Okay, again these are the investigations which you need to do. Okay, the same thing, so I'm not talking much on. Okay, based on the etiology you need to. Okay, what about golideckel cyst? Again, this is an important thing. Make sure you know about the Jordanis classification. Okay, that thing you can be asked for 3 markers separately. So mention about it and write it. Okay, Kazov's law, very important for your 3 marker. What does it say? In the case of obstructive jaundice, if gallbladder is palpable, then it's seldom. That is, it needs likely to be a gallstones and it most likely be a carcinoma. Okay. Though there are exceptions, make sure you what are the exceptions for this? Double impacted stones, large stone in Hartmann spots, or posterior cholecystectomy. Okay, then this is the explanation for 3 markers. Whatever you have to write, you have to write. Charcos and Murphy's pentad, important thing. I don't know how many times they have asked, even in RS4. What is that? This is to diagnose acute coli. This is to check whether he has entered into complication like sepsis. So what are the triad? Intermittent jaundice, colicky, intermittent pain, and intermittent fever. That is, it's not continuous, it's being intermittent. But once it develops shock and altered mental status, then you will go with acute obstructive cholangitis. So you will have your leukocytosis as well as deranged epilepsy. Where is it seen? Acute cholangitis. Again, this is the possible important 3 marker. As I told, what are the indications of ARCB? Again, you can diagnose something, or you can treat something. So what are the things which you can treat? You can remove CBD stones, you can do a biliary stenting, and you can treat bile leak after a open surgery. And what are the uses of its diagnosis? You can diagnose obstructive jaundice or CA head of pancreas while taking HPE. These are the possible complications. Again, CBD exploration, wherever you do, again you can do it as a pre-op or intra-op or post-op. Same narration, you can just follow it. Again, next important thing which you need to study is about spleen. Again, causes of splenomegaly in and out in medicine, it's an important medicine topic. If you ask about what is the important thing about surgery, I have to talk about splenic rupture as well as OPSI. Okay, these are the same things. I am not. Make sure you mention about all these things. Okay, case sign and all those things. What are the indications for splenectomy? If it's a traumatic, then you have to do. Again, in surgery, what is the narration which follows? Traumatic, non-traumatic. Again, here, basically, these things, without talking local things, we'll go with systemic things here. Might be due to hereditary spherocytosis or ITP. And these are the other malignancy causes and other causes which you need to go. In and out of complication of splenectomy is that, again, what I told, by writing complication of a surgery, you need to divide it into intra-op and post-op, and early and late. In late, in and out of OPSI is required. You should know what are the vaccinations which you give. Okay, Neisseria, meningitis, hemophilus, influenza, and pneumococcal. And how do you prevent it? The same thing. Okay. Again, next important thing which you need to study is about rectum and anal canal. Okay, major thing is about this, and these are the possible 3 markers. Okay, pyrenoidal sinus, it's also called as Reed-Traverse disease. Why? Because of the ingrowing of the hair into the subcutaneous tissue. Again, what is the important thing which you see? The treatment. Okay, hemorrhoids, I'm sure you know it. The classification part, based on where is the venous hemorrhoid which is present. If it's permanently, it's 4, but if you can put it back, then it's third. But it's only if it's only coming during defecation, it's 1. But most important thing what people forget is about the surgery part and this part. Okay, we have to talk about this and that. Okay, these are the treatment which options which you have. Again, abscess, what do you do? Incision and drainage. Fistula and inano. This draw a diagram and placed on the place this, label this and come back. Which side should? I'm sure this is a favorite fiber question, so I don't think I need to discuss. Based you are predicting an opening of the fistula based on the external opening. Okay, so I'm sure if you even you just see this, you will understand. Again, fissure, important thing, you need to manage it acutely. Then you have to go with all your uh, uh, major management. Okay. Again, rectal prolapse, it's not as you can just study, so I'm not talking much about it. It's not an important question. Okay. The next important thing is about the intestinal obstruction part. So again, major important thing you study about this. Again, if you have time, you can study about this. Though this is not an important one, but in and out of this is important. Again, if it's an obstruction, whether it can be some due to actual obstruction or it's a functional or a physiological thing. Okay, this is common than this. Again, if it's an obstruction, it can be an obstruction inside or an obstruction outside. So based on this, I have placed a classification. Again, go with the same thing, same narration, nothing more, nothing less. Again, what is the treatment? You have to know. It's a clinical diagnosis. Okay, based on the auscultation only, you can come to know whether it's obstruction or not obstruction. But it's an surgical core emergency. You need to go and decompress it. Okay, major thing is aspiration, prevent aspiration and resection and anastomosis. Intersubscription, what happens? Okay, this is intersubscription. It's one part of bowel herniates and goes back to the same part. Where is it common? In the ileocecal section. Again, same thing. What are the same examination? Whatever I have to present, I have presented it. Make sure you know it and come back. Same operation. Volvulus. Whenever it twists, okay, that's called volvulus. Sigmoid volvulus is something which is more common. Okay, I'm just mentioning the important. I'm just marking you the important things because even I know that there is more time to study for this paper, and also we have reached at the end part where only one question will be asked from all these things regarding gastro. So I don't want to waste much of your time. I want your time to be invested in ortho as well, and also the other part of neuro paper too, so that you score good marks. Because if you study only this part, only gastro, then you are out of the race in the first part itself. Please don't study gastro on a day before exam. At the starting, if you have just one day, if you have 2 days, then it's left to you. But if you have just one day, please don't start with gastro. Always start with uro first. Always next start with neuro bar CTBS. Next start with vascular. Next start with gastro. Provided you know pancreas to study first, hernia to study first, then study whatever you want for namesake. Because only one question will come out of that. Okay, only one. That to 5 marker or a 3 marker. So please don't play with time. Please don't play with time. Okay. Again, paralytic ileus. It's a post-surgical thing, so I'm not talking about it. You have to mention all these things. Okay. Then see, now there are 17 chapters based on your SRVK thing, but this only has separate marks. So this is what is the weightage of this part, either 5 mark or a 10 mark. And even in 5 marker, what is 5 mark or a 10 marker, what is the predictable question, which is the appendix, bar, rectum, or you might have a gallbladder question. Do you need to study this? If you want, you can skip, provided you study ortho. But why? For my completion's sake, I'm just mentioning it. It's nothing to do about surgery here. It's all about anatomy. What are the types of peritonitis? I'm sure you would have studied in anatomy. I'm not explaining it. If it's after 48 hours, then it's called. And if secondary peritonitis failed, it's called tertiary peritonitis. And no, I'm sure while writing etiology, what it is, so traumatic, not traumatic, in traumatic, again go with the Robbins. Okay. So all the stages, I would say don't study the stages only. Don't study. Because you are wasting a lot of your memory there, because you need to score marks in the other part. Don't study. Again, same thing, I'm sure you know it. Again, to diagnose, to look for complication, and to support. Again, you have medicine into picture. Again, you have to look into electrolytes as well as metabolic component, whether it's acidosis or alkalosis. These are the treatment. Major is this and this. I mentioned about ABC. Again, subchronic abscess. You just draw this diagram and the same clinical feature. Okay. See, it's a clinical diagnosis. Okay, if patient is not responding well, you should always think about subphrenic access. The same thing again you do the, if you are unable to diagnose, obviously you will get gallium 67 scanning. Why? You will attach this part and you will check where is the WBC going. You will just know about it, but again if you don't write you won't get marks, and if you write also you will get almost the same marks. Again you need to drain the abscess, treat underlying cause, and also you need to treat. Okay. Again, mesenteric cyst, based on, okay, this is the possible tree marker, this is the concept. All mesentery is one organ, okay, and due to the lymphatics and blood supply, and if embryology, if any three of them are failed, and if any one of them has failed, then it will form a mesenteric cyst. So it can be either chylolymphatic, so lymphatic has failed, or it is enterogenous, that is duplication cyst from the intestinal diverticulum, that is double, or it might be something to do with embryology, that is urogenital, or it might be dermoid cyst. Okay, this Tulakstrad, an important remark. Abdominal tuberculosis, go with the same narration of tuberculosis, nothing less, nothing more. Don't write about all these things. Again, same thing. Okay. If you want, you can then abdominal TB, study ileocecal TB. Okay, same thing. See, what are the this is one thing which you need, which is important for surgery. Okay, what are the types of ileocecal TB? You can have ulcerated, hyperplastic, or mixed. Okay, same narration. If you have obstruction, then you need to go and do all these things. Otherwise, you start with 80 to 9, nothing less. Okay, these are the things which you say. Liver. Okay, liver is something actually important. See, for all these things, tips, BCS and HRS, though it's a medicine topic, as I told, I will explain in surgery. Make sure you refer page number 669 of SRB. Okay, because see, as I told, it's not an important question. Okay, you need to know what to study day before exam. I'm not saying this will never come. This might come, but I'm sure you will write something and you can fetch half of the marks. But the goal is to first pass, correct? So that doesn't require you to study everything. So make sure you study these things. Again, this is something which I'm sure you are discussing in from second year. What is hydatid cyst? It is due to the same thing which you need to talk about. Again, the treatment part I will just explain. Okay, you have to, these are the principles which you need to maintain. Major thing is this, because it will cause recurrence, and also these are the treatment protocols which you do, and any patient will start with praziquantel with albendazole, and this is something which you can try, but if it fails you have to go with pericystectomy. Second is in liver. Again, you have to divide it into abdominal and extra abdominal cause. Again, it might be due to, you have to write about synchronous and metachronous. Okay, based on these two words they might check. Okay, this is a 3 marker. Clinical features, same investigation, treatment, it depends. It's almost, if it's a secondary is liver, depends. If it's one, you can operate, resect the liver and operate, otherwise you go with palliative chemotherapy. Again, portal hypertension, it should be more than 10 mmHg, divided into pre-hepatic, hepatic, post-hepatic. Make sure you draw a diagram, pre-sinusoidal, sinusoidal, and post-sinusoidal. If you write this, I am sure the causes will come into your mind and you can place it. Okay, these are the clinical features which you need to explain. I am sure you have studied in medicine, and these are the examination findings, and this is the investigation and treatment. Also. Okay, esophageal varices, again divided into primary, secondary, tertiary, and quaternary based on the classification which is given in SRB. I'm just explaining it. Again, I'm sorry, beta blocker is given in the esophageal varices part. Okay. Not in the portal hypertension, I'm sorry. But one of the complication is this itself. Okay. Again, all these things. I'm just underlining things which you need to write. Again, RAF ka DD, this is a possible 10 marker, sub-question of 10 marker is what I would say. Okay, divided into parietal and intra-abdominal spelling, because this is how you have learnt in WATS. So make sure you show that you are going to watch. Okay, so divide it and just present it accordingly. Okay, then also have ectopic structure in the intra-abdominal spelling itself. Make sure you study this and come. Okay, major people, even while in WATS you forget it, but even in females, right, specifically in females, you can see all these things. Okay, again, important thing is this, not important. Okay, I'm not explaining because of the fact I know it's not important. Okay, then I just explain you the again causes of dysphagia. It can be high level dysphagia or low dysphagia or esophageal dysphagia. Again, it might be due to neurogenic problem or anatomical problem. Again, anatomical, I'm sure you will write about this, but neurogenic, you make sure you write about this. Okay, these are the, see, I'm saying you, if you are studying TNM, staging of esophagus and stomach, you are a fool, man, because Possibly it can come as a 10 marker or a 5 marker, but it won't affect your marks, because at the end all your gastro part will go in waste, because if this comes as 10 marker or 5 marker. But I'll give you the concept. Okay, what are the things which are studied in histology? First, what is the layer you have, then what are the other layers you have? You have first mucosa, correct? Then submucosa. What do you find in submucosa? You have lymphatics and blood vessels. Then what do you have? What else do you have? You have the plexus, nerve plexus, mind plexus. Then you have all the other things. Okay, that is fine. What happened? Then from mucosa, what is the type of mucosa which you have? Columnar. So it's a adenocarcinoma thing is more common than squamous carcinoma. And what about the submucosa? What is there? Lymphatics and blood vessels. So from lymphatics, what can develop? You can have maltoma, or you can have other types of lymphoma. Then blood vessels, what you can develop? Hemangioma. From plexus, what you can develop? Schwannoma. Okay, then later again you might have from serosa, you might have any advanced stoma. And also from muscularis, what you can develop? Leiomyoma. So I have this concept in mind, then you can just place the disease and come back. Okay, but what is why is SCC more common in adeno and esophagus? Because what do you have? What is the layer lining the mucosa of esophagus? It is squamous cell. So that is what important thing. Okay, I'm not explaining this because I have told you the general template on how to write about it. So I just fit those into the place and come back. Again, achalasia cardia, write about Eckhart score. Then again, treatment. I'm sure you have to mention about Hellas cardiomyotomy with two-phase fundoplication. Then types of TEF, important for 3 marker. Okay, first you will have esophageal atresia, then connected proximally, then connecting distally, then connected both proximally and distally without connecting esophagus, but in E you will have connected H. Okay, again the same clinical feature, I'm sure you will write about it, but while writing investigation, mention about rule out Vactrel anomalies. Okay, these are the treatment part. So case giving, I'm sure you can write about it. Barrett's, again Seattle protocol. Okay, mention about that. It's a 3 marker match, so I'm not wasting much time on it. Stomach, I have told you, CS stomach important, but again this is more important. Okay, again if you have time you can refer it, but CS stomach, I've explained you the general concept on how to fit your malignancy into place. First you have to write general weight loss cachexia, then due to tumor, then due to lymph node. Okay, that is spread, and again due to malignancy, again you have liver or abdomen. So based on that, write the know the physiology, block it, and make it pathology, and write the diseases. Okay, again congenital hypertrophic pyloric stenosis is important, 3 marker. What is the important thing which you need to know? Correct electrolyte abnormalities. Okay, then you go with Ramsay pyloromyotomy. Key pictures is what key wordings is what all will see, man, because they have just 20 minutes or 10 minutes per time, and they are going to evaluate for your whole second year, third year, fourth year ka knowledge for just 40 rupees. So think of it, and they have a lot of duties to do as a surgeon also. So you need to place those things, you need to write the general template, then make sure underline those things, show them what you know, come back. Peptic ulcer, I don't know what else I have to say, but complication you have to mention. Okay, say stomach, the same thing. I'm not mention the names. Okay, I'm just highlighting, I'm not explaining anything. Staging, don't study. If you ask me, don't study. Okay, directly I'm saying, because even if you know, right, if you write the staging and come back, you might get extra 1 or 2 marks. Okay, so better don't study, but write all the investigations. How do you do? Also the management part, I'm sure you can do. Stage 1 and stage 2, just right, you can do with surgery. But even in stage 2, stage 3, do NACT, then plan for a surgery. Remaining thing, you can just write palliative chemotherapy. Okay, so why do you, though it is important, but you should know how to fetch marks. That's what I'm just saying, just for 3 markers. Okay, carcinoma tumor, which is the most common site? Appendix. Okay, make sure you know about it. Crohn's and ulcerative colitis, in and out are discussed in your medicine. So make sure you can just refer that. But why are they asking in surgery part of it for this suturectomy? Okay, about only one thing they're asking. Okay, then again, causes of mass in RAF, I have told you, explained you there itself as a part of 10 marker, but it can be a sub-question in 10 marker. An important thing. Again, major thing here is spoon and colostomy for 3 markers. Again, about the disease itself, I mentioned these are the clinical features. It's important. Okay, this is an important question, though it's a pediatrics overlap, it's an important. Okay, to diagnose, it's a clinical diagnosis. than a clinical diagnosis. I would say it's an investigation based diagnosis itself. Then again you have IHC also, which comes into place, but I don't think I mentioned here. It's okay for our level. I don't think it's also necessary also. Okay, mention about this. Then again, what is the definitive treatment? You have to wait till the baby gets 10 kg of weight, then exercise the equine segment and do a anastom exercise. That is called as modified downhill ulcerative colitis in and out. I have discussed in medicine. You can go and present it. So treatment, course, general surgeon's topic. Okay, this you need to know in and out. Okay, what is that? You are creating an opening for the fecal matter to pass out. Okay, so either you can create temporary or in a permanent. Okay, where do you go with the permanent thing? If you have a malignancy of colon, which is palliative. Okay, or in anal canal also, or after Hartmann's procedure, it's actually a temporary thing. Okay, even in where do you go for temporary? What is the meaning? You're creating healing in the area by feces. This is the meaning. CA colon, possible 10 marker might be, but start with the same narration. Remember AK57, I'm sure you write about this pathogenesis if it's as per a 10 marker based on the Robbins diagram, I'm sure which you have studied. Then mention about Duke staging. Again, it's based on mucosa, submucosa, muscularis involvement, which I'm sure I've explained you there. Again, go with the same clinical features parts which I've explained you. Again, general, systemic. Again, systemic, what will you write? Specific to those symptoms. Again, you will write about lymph node also, and again metastatic part you will mention about lungs and stomach as well. Again, investigation, again for screening, this is what they check, FOBT. But if he already comes with blood in stools, will you do FOBT? No, it's a foolishness, because FOBT is done only to check for blood. Okay, any as I told, even in medicine, any idea in men is bleeding, GI bleeding unless pronounced. So it might be either due to hemorrhage or even due to or any kind of carcinoma. Even if the patient has hemorrhage, it's your duty to do a colonoscopy and rule out malignancy. Okay, so that is the importance of knowing all these things. I know at the end all will pass the exams and all will come out of flying colors, but to treat that patient or to save that patient from going to next stage is something what should learn. Okay, the same thing. Okay, same thing. I'm not talking anything. Again, you have to write about follow up. Again, you write about the prognosis. Okay, that's it. I think I have not taken much of your time. That was the aim of the overall thing. My aim was to make sure you study the same pattern which I follow. That was the overall aim. Okay, I'm not sitting here to waste your time here. That thing I think you should understand. My major aim is to make sure you know what I am predicting. Okay, I am not predicting based on any other things, based on what they have asked and what is more common. So make sure you study in the same way. I don't think I have to repeat it again. If you want, I am ready to repeat it, because I don't want people to study gastro full day and then don't read up ortho or do something vice versa. Always study with Euro first, then go with CTVS by Neuro, because these are the things which they see. First, if you have to pass paper 1, paper 2 for 50 marks, what is the marks which you need to get? 60 40 cup if you do, so 50 marks. So either minimum 25 you should get. No, so out of this, these three things will come back, and this is either year or year will come based on your luck. So why do you need to study gastro is my question. Yeah, you need to study gastro. Either one question for 5 marker or 10 marker will come, but even if you leave, if you leave, what is the marks you are getting? Though I am sure you won't get 35 out of 50 as an out of 4, but I am also sure you won't leave that gastro question, because you know the basic template, you know the basic knowledge, and even they will give you half of the marks if you write that. So I hope you're understanding what I am trying to say from this. Though I have explained how the narration goes from medicine, in the medicine part of it, I have taken time and explained how the narration goes for AKI or CKD, how do you go for nephrotic, because it was required. Because that's how you will develop concept there. But in surgery, it's not like that. Here, the aim is to pass, man, because the portions which you have in paper 2 is vast. It's proper systemic surgery. So you need to, first aim is to pass, and in the subsequent videos we can explain you the concept and do all those things. But what is the aim of this video? Aim of this video is to make sure you study properly and study those topics a day before exam, so that you know specific things regarding that and you just place it and come back. Though the overall aim in surgery part 2, what I feel is they're testing whether you have gone to wards and whether you have done your examination part well, whether you have attended case discussion, whether you know the proper surgical part of it. Because hernia is a short question, and also your vascular part, your venous ulcer, or it might be your varicose vein, or it might be your POID, all those things they have placed as a short question for the fact that they just want you to test whether you have gone to wards. And also procedure related things. For example, it might be RCP, MRCP, what they're trying to say, whether you have gone into wards, whether you have seen. And what about the neuro part or CT-based part? They have just kept it to 1 or 2 marks, and that too it's overlap with your forensic or anatomy part of it. I'm sure one question for your 10 markers in either of your sessional or your final exam, you would have had STH or EDH. Correct? No, they're not testing you that concept. They are testing you whether you know, whether you have attended what. So basically they are testing you whether you know the proper core general surgery part of it, not your super specialty part of it. So though the gastro or uro comes under that, the uro has a sequential narration and the proper narration like nephro of medicine, which I have taught you based on the clinical feature investigation. And what are the major investigation? One additional investigation is to do RFT, so that you look whether the patient is going to CKD or not, and also you do DMSA to look for scarring. So it has the same narration. So the euro is not at all a problem because it has the same narration, and you can just study some specific points about each disease and place it and come back. But gastro takes hell lot of time, and if you have not done gastro before, my advice is to don't touch gastro, but do pancreas and do hernia part of it and go. So make sure you study accordingly and don't waste time on gastro. I know gastro is an important part, as a super specialty part of it, but limiting to your MBBS knowledge is not an important thing. General surgery is an important thing. The paper itself is general surgery, right? So make sure you know about it, then place it accordingly. Okay, that's it. And again, I would advise you to start with the same narration and start with the same chapter which I have told, so that you don't waste your time on gastro. Otherwise, if you are wasting time here, you are using your time in ortho. So left to you, decide whatever you want to do. Thank you.